This is a poster abstract that I'm presenting with Dr. Sanam Lachowiez as one of the senior authors on it, who's been integral in my continued mentorship. And we wanted to evaluate the variant allele frequency cut point. So as opposed to the NPM1 blast enumeration threshold, for instance, that we talked about in ICC-ELN, ICC-ELN actually has a SF3B1 variant allele frequency cut point where something over greater than or equal to 10% is considered to be SF3B1 mutated MDS, whereas if it's less than that, it's not considered SF3B1 mutated MDS, as long as you meet other criteria for this disease entity. And so we first filtered, again, the International Working Group for Prognosis and MDS for patients with SF3B1 defined MDS or chronic myeloid neoplasms, and then we separated them based on if they had SF3B1 low, which is a VAF less than 10%, versus greater than or equal to 10%, which we termed SF3B1 high. And there actually is a minimum cutoff as well. It should be 5%, but we used all the variant allele frequencies that we had just to compare two dichotomized groups and make sure we had some power for this analysis. Which is important because SF3B1 low cases are not very frequent. They were only found in the minority of cases, about between 30 and 40 patients overall, whereas most patients had higher variant allele frequencies. And what we found was that, looking at survival only by SF3B1 variant allele frequency, we didn't actually see any significant difference in leukemia-free or overall survival when we adjusted for other variables. But what we did see is that the genomic landscape differs between these patients with low VAF SF3B1 mutations versus high VAF or higher VAF, 10% or greater SF3B1 mutations. And so what this cut point probably is doing for us is identifying cases of SF3B1 mutated MDS that are sub-clonal to other driving genomic changes and other genomic drivers, I guess would be a better way to put that. And indeed, most cases with SF3B1 mutated MDS with a variant allele frequency less than 10% were subclonal to another mutation, about 60 to 70% of those cases. Whereas in the higher group, most of those mutations were codominant with the other mutations within interpatient samples. And a lot of this genomic variability can be captured nicely using the IPSS-M score. And so it tells us a couple things. I think the main take-homes are that using a variant allele frequency cutoff of 10%, we're identifying more subclonal cases of SF3B1 mutated myeloid neoplasms, where the SF3B1 mutation in and of itself is probably not the main genomic driver compared to cases where SF3B1, the variant allele frequency is greater than or equal to 10%. And that diagnosis, this is identifying two groups with differing disease biology, does not necessarily equate to prognosis. And when we think about prognosis, we really need to be using risk calculators that encompass the entire genomic landscape, like the IPSS-M score.